Hello, and today we're going to talk about sedative, hypnotic, and anxiolytic medications. Specifically, we're going to talk about a class of drugs called barbiturates. Primarily, these drugs were initially used to treat insomnia and anxiety, and we'll talk about their development and some newer alternatives in later lectures. Today, we'll talk a little bit about some historical background for this class of drugs. As the name suggests, they're sedatives. That is, they're used primarily for relaxing patients and for inducing a relaxed state. They're often called hypnotics because in previous decades they were used in conjunction with hypnosis to create an altered state of consciousness. Not done as much anymore, given that hypnosis has really gone by the wayside. Let's first talk a little bit about anxiety and anxiety disorders. They were first classified as an actual psychological disorder in the third Diagnostic and Statistical Manual released in 1980. Since then, DSM has expanded to include several categories of anxiety, but in general, anxiety is a type of common psychiatric disorder characterized by excessive rumination, worrying, uneasiness, apprehension, and fear about future uncertainties, either based on real or imagined events, which may affect both physical and psychological health. Importantly, this type of disorder affects about 18% of Americans suffer from some form of anxiety. Whether or not it requires treatment medically, it depends on the severity, but there are a variety of anxiety disorders, including panic disorder, obsessive compulsive disorder, social anxiety, etc. So these drugs were initially thought to treat these kinds of disorders. Of course, initially they were developed long before anxiety was recognized as a disorder, but people certainly recognized what it meant to be anxious. So let's take a look at some of the early sedatives. These date back to the mid-19th century. Bromide and chlorohydrate were the first sedatives that were not alcohol or opium. Keep in mind at this point opium was a legal drug. And at the time, a lot of people self-medicated with alcohol and smoking opium to relax. In 1912, phenobarbital was introduced as the first barbiturate. There have since been some 50 different barbiturates marketed between then and 1950. Phenobarbital, thiopentanol, all sorts of different drugs have been used both for sedation and as an anesthesia in surgery. In fact, sodium pentothal is used quite a bit as a general anesthetic, particularly in outpatient settings. And we'll talk more about that later on. In the 1950s, though, we get the introduction of the benzodiazepines. In 1960, chlorodiazepine, or Librium, was introduced. This was the first of the benzodiazepines to be introduced. Later on, of course, we get Valium, or diazepam, which is introduced in 1963. Which quickly went on to become the most prescribed drug in the United States from 1969 to 1982. Benzodiazepines as a class are still one of the most highly prescribed drugs in the United States. I think they're number 2 or number 3 at this point. So still significantly used. Valium was the number 1 prescription from the late 60s to the early 1980s. Now, there, of course, were significant problems with this high level of Valium use. In fact, it became part of the social fabric. Lots of people taking Valium. It was sort of the in thing to do. Of course, we now know that Valium can be addictive, and there is some question about the social implications of Valium use. In fact, there is a fairly classic feminist book called The Valley of the Dolls, which targets the use of these drugs as it relates to feminism. So if you want to read more about this, there are a couple of great books. The Feminine Mystique is certainly one by Betty Friedan, and Happy Pills in America by David Hertzberg, which talks about the history behind Valium. So one of the important things to understand about these drugs that we're going to talk about is that they're classified very differently from others we've talked about. Previously, we've talked about drugs as it relates to their action. So, for example, SSRIs affect serotonin, so we talked about them as being selective serotonin reuptake inhibitors. In the past, however, drugs were classified based on structure. So while we currently classify drugs based on their effect, SSRIs, norepinephrine reuptake inhibitors, etc., in the past, drugs were classified based on their structure. We talked about this with tricyclic antidepressants. Barbiturates is another example. And the benzodiazepines. Now, the benzodiazepines are nice because that structure of chemical affects a specific receptor site in the brain. And so we can talk about them as a class because they do have the same effects. So today, barbiturates and benzodiazepines would be considered GABA receptor agonists. But that's not what we call them because we're stuck with barbiturates and benzodiazepines. But it's important to understand how these function because they do significantly affect the neurotransmitter GABA. As we've talked previously, GABA is an inhibitory neurotransmitter. Remember, GABA is gamma-aminobutyric acid. So substances that are GABA agonists therefore inhibit neural firing, so it's no surprise that sedative drugs would have an inhibitory effect. In fact, they are sedatives because they have an inhibitory effect. Importantly, there are specific receptor sites for both barbiturates and benzodiazepines on the GABA receptor. Some drugs are benzodiazepine receptor agonists, which we're going to talk about, which are things like zolpidem, which is Ambien. Other nearby receptors include alcohol and the anesthetics that we're going to talk about. So let's take a look at what a GABA receptor looks like structurally and some of the drugs that are going to affect GABA. So here we might have a chloride ion channel. The GABA site is GABA bound to this receptor. We get an influx of chloride ions, which makes it less likely this neuron will generate an action potential. There are benzodiazepine sites, which both benzodiazepines and benzodiazepine receptor agonists affect, so drugs like zolpidem. Barbiturates, also on this site, and also there's a site for general anesthetics, which includes things like propofol, steroids, halothane, and ethanol, which is, of course, alcohol. All of these affect the same neurotransmitter, so they have an effect on GABA even though they have their own receptor sites. So GABA is a widely found neurotransmitter in the brain. Benzodiazepines exert their anxiolytic properties by acting on the limbic system, which includes, of course, the amygdala, which is the part of our brain responsible for our primal emotions. Also, our orbital frontal cortex, which is going to be involved in our interpretation and our understanding of those emotions. The side effects of benzodiazepines and other sedatives include, of course, sedation, which is people relaxed, often very sleepy. In fact, oftentimes will be very sleepy. Reduce seizures. A lot of these drugs are used to prevent seizures or to treat seizures. Oftentimes they're used to treat alcohol withdrawal seizures. They are associated with significant cognitive impairment, but they're also used as muscle relaxers. So these drugs have quite a few uses. All of these effects result from effects in the brainstem, throughout the cortex, and of course the hippocampus, which is going to be responsible for a lot of the cognitive impairments. We know that GABA is involved in anxiety because if we block GABA functioning, we end up with what we call anxiogenic actions. That is, you end up creating anxiety. And in fact, we'll talk about GABA and its role in anxiety and nicotine when we talk about nicotine and tobacco. Important thing to understand about this class of drugs is they have very significant cognitive effects. In fact, most sedatives can induce amnesia, particularly the benzodiazepines. Most of you are, of course, familiar with the idea of an alcohol blackout. Hopefully you haven't experienced them, but you are familiar with the idea. And the basic idea is that a high level of alcohol can result in what we call anterograde amnesia. That is an inability to form new memories about an experience while you're under the influence of high levels of alcohol. This type of blackout or amnesia is even more likely when we combine alcohol with sedatives, in particular benzodiazepines. So they're particularly dangerous to combine benzodiazepines and alcohol because they are highly likely to result in significant amnesia. Do want to point out that this kind of anterograde amnesia is studied significantly, particularly in the benzodiazepines. and it is important to understand that alcohol has an important component. High levels of alcohol can cause blackouts or amnesia on their own. If you're at that point, that's a highly dangerous level of alcohol. So this is something we really want to try to avoid. GABA plays an important role in amnesia caused by these drugs. Memories are thought to be formed by a process known as long-term potentiation, or LTP. And GABA is known to reduce long-term potentiation in the hippocampus where memories are formed. So we know that LTP is a significant neural process involved in the formation of longer-term memories. And we know that GABA can reduce that process. So whenever we increase the function of GABA, we end up reducing long-term potentiation and thus reducing the formation of memories. Again, this is important to understand when we're talking about these sedatives because people under the influence of these drugs will have reduced memory functioning in general and can have significantly reduced memory functioning to the point of amnesia. So when we talk about having significant GABA activation from these drugs, we can therefore result in what we call a drug-induced reversible organic brain syndrome. Essentially, it's like temporary reversible brain damage where the person has amnesia for the time that they're under the influence of these drugs. Now, oftentimes we use this in a clinical setting for good purposes. Sometimes it's important to block memories of traumatic events. But they also have a significant potential for abuse. In fact, this is what we often call date rape drugs. And almost all of these are sedatives or benzodiazepines. So all sedatives have the potential to cause amnesia at varying doses. Some drugs have very potent amnesic effects. We're going to talk about gamma hydroxybutyrate, which is GHB, Rohypnol, which is the sort of classic date rape drug as it is, Versed, which actually is mostly used clinically, and Ativan, which is lorazepam. All of these have very significant amnesic effects, in particular when combined with alcohol. Some of these drugs are very dangerous when combined with alcohol. In particular, GHB can result in significant reductions in respiration. And, of course, if you're not breathing, you're not living. So, very dangerous drugs to combine with alcohol. Importantly, those people who are under the influence of these drugs are unaware that there's anything wrong with their memory. And we've shown this in a paper I published in 2004 in which very significant amnesia induced by Versed or midazolam, participants completely unaware of that happening. Importantly, this research has been replicated with other drugs including lorazepam and diazepam and zolpidem. So all of this class of drugs have significant effects on memory, and most people have no idea that there's anything wrong with their memory until the next day they can't remember anything. So there is serious dangerous potential for abuse as date rape drugs, particularly GHB and Rohypnol. Versed is almost impossible to get a hold of. It's also only injectable. Ativan is another significant one that's much easier to get a hold of. So very important to understand that there is some danger involved in these drugs. They do have clinical uses, however, and in fact we oftentimes talk about their use in what's called a conscious sedation procedure. And in a conscious sedation procedure, the patient is given a drug, usually midazolam, in which the doctor doesn't want the patient to remember the experience. So there are some clinical patients or procedures that require patients to be awake and responsive. For example, if you are undergoing what's called an endoscopy, where a fiber optic tube is going to be put down your throat to look into your stomach, you have to be awake to swallow the tube, but it's apparently a very unpleasant procedure. So they'll give you a drug like midazolam, so you won't have memory for that sort of traumatic experience, but you'll be awake and responding. Similarly, oftentimes when people have their wisdom teeth pulled, they'll be given a dose of midazolam and fentanyl, which we'll talk about when we talk about pain relievers. Very common for those two drugs to be used in conjunction with one another in lots of outpatient surgical procedures. So in these clinical procedures that require patients to be awake and responsive, they can be given midazolam to alleviate anxiety and to keep them from remembering unpleasant procedures. So in a couple publications I've been involved with, we use this drug to induce very dense amnesia. Participants were awake, answering questions, responding to questions on the computer, but had no memory for that experience. these drugs are oftentimes given in sort of long-term situations to prevent traumatic memory. So, for example, burn patients oftentimes will be kept kind of on a steady diet of midazolam to keep them from having traumatic memories of their treatment. Burn treatment is particularly painful and traumatic. And so to keep them from having that trauma, we just simply block their memories from being formed. Okay, so a little bit about the cognitive effects of these drugs. I want to talk a little bit about barbiturates. These drugs really aren't used that much anymore, certainly not much on an outpatient level. The indications for this class of drugs include general anesthesia for surgery. They can be used for epilepsy as anticonvulsants. In hospital, they might be used to maintain a coma in emergency situations. So if somebody has a head trauma, and it's better to keep them in a coma to protect their brain, these drugs are used for that. They can be used to treat bipolar disorder. They can be used to treat anxiety, and of course, to induce sleep. Talk how the pharmacokinetics of these drugs work. They all have varying half-lives, so do the benzodiazepines. We'll talk about those later. They can be short, very short, for example, 3 minutes, to very long, 48 hours. So widely different varying half-lives for these drugs. Ultra-short-acting, like 5-pentanol, are extremely lipid-soluble, cross the blood-brain barrier rapidly, and induce sleep within seconds if they're given intravenously. So these drugs are usually given as anesthetics. The longer-acting ones, like amylbarbital, are more water-soluble. They're slower to penetrate the central nervous system, and so are more likely to be used as a longer-term solution, not as a rapid intravenous anesthetic. These drugs can be tested for by urinalysis, just like many other drugs, and so there is some potential for abuse from these drugs, so they can be tested as a drug of abuse. Quick review of all of the sort of general barbiturates that are used frequently. Thiopentanol, phenobarbital, all of these are used to treat things like, are used as anesthesia. Some are used to treat insomnia or epilepsy. Really just depends on the elimination half-life of the drug. You can take time to review this. We've talked already about the effects of GABA. Barbiturates are GABA agonists. So much like the benzodiazepines we talked about, barbiturates, some steroids, and even alcohol all bind to receptor sites from the GABA, at different sites from GABA itself. So they all modulate GABA. They don't affect GABA directly, but they actually can boost the functioning of GABA or reduce the functioning of GABA. All the drugs we're talking about at this point are boosting the functioning of GABA, so they are anxiolytic or sedating. In terms of the pharmacological effects of this class of drugs, they are not analgesic. That is, they do not reliably produce sedation or sleep. They don't produce sedation or sleep in the presence of pain, and they don't reduce pain. While they can induce sleep, REM sleep and therefore dreaming is suppressed when people take these drugs. So when they stop taking them, they have vivid and excessive dreaming during that withdrawal period, what we call REM rebound. There's, of course, significant cognitive inhibition, including sedation, memory impairment, alterations in judgment, and cognitive functioning. Just like alcohol, these drugs can significantly alter a patient's judgment. Barbiturate-alcohol combinations are particularly dangerous. They're clearly implicated in both accidental and intentional suicides. Lots of famous examples. Marilyn Monroe, Judy Garland, lots of significant celebrities who have been involved in combining barbiturates with alcohol and resulting in accidental overdose. So, one important thing to understand about this class of drugs is tolerance can be induced. That is, the liver will start to become very good at processing out barbiturates and will become more efficient at it. So they will eventually, patients will get higher and higher tolerances, and as a result need higher and higher doses. It's one of the cycles of tolerance and abuse we'll talk about later. The final psychological effects is there are clear behavioral, motor, and cognitive inhibitions similar to alcohol, as I mentioned earlier. And it's important to understand that at higher doses we get general behavioral depression and sleep. So oftentimes people who have overdosed and don't realize it will have gone to sleep and not wake up. So again, very, very dangerous class of drugs, and certainly high potential for abuse, which is why the clinical use has declined. And in fact, it's declined for a variety of reasons. They are lethal in overdose. There's a narrow therapeutic to toxic range. There's a high potential for dependence and abuse. These have a high potential for addiction and dependence, and incredibly dangerous interactions with other drugs, particularly any other sedative drugs like alcohol. Tolerance is induced in a couple of ways. First of all, as we talked about a moment ago, induction of metabolic enzymes in the liver will make the body faster at metabolizing this drug out. And furthermore, neurons will adapt to drug presence and stop responding. And so there is significant adaptation to the presence of this drug. This results in a risk of both physical and psychological dependence and increasing doses to get the same effect. I want to talk a little bit about some non-barbiturates that sort of fall in between barbiturates and benzodiazepines. They're structurally resemble barbiturates with slight differences. They were introduced in the 1950s as anxiolytics, sedatives, and hypnotics. They're really medically obsolete, but they are occasionally encountered as drugs of abuse. The two that I really want you to think about are methylqualone, which are quaaludes. Lots of use in the 70s and 80s. Rivaled alcohol and marijuana in popularity for abuse. Again, possible date rape drug, dose for anterograde amnesia, lower than for incapacitation. So people will still be awake, but incapacitated, but amnesic for the event. And then the other is, of course, GHB, which is, again, potentially a date rape drug, has high toxicity when combined with alcohol. We're going to talk about it as a drug of abuse. Oftentimes it's used in combination with methamphetamines, and we'll talk more about that later on. There is some belief that it could be used to treat narcolepsy. This drug used to be available as a supplement from places like GNC. It actually helped build muscle, but it has very significant sedating effects and is a very dangerous drug to combine with, certainly to combine it all with alcohol. Okay, well that's our introduction to sedative hypnotics. We're going to pick up and talk about benzodiazepines in our next